Good afternoon, everyone. I am Wendy Murray, currently the past president of the American Society of Biomechanics, and I'm here today to introduce the 2019 ASB Borelli Award winner. The Borelli Award is the most prestigious honor given by the American Society of Biomechanics. The award is named after Giovanni Borelli, a mid-17th century professor of mathematics from Naples, Italy, considered by many to be the father of modern biomechanics. The Borelli Award recognizes outstanding career accomplishment and is awarded annually to an investigator who has conducted exemplary research in any area of biomechanics. The Borelli Award is open to all current ASB members, excluding current ASB officers. Nomination packets include a nomination letter, a comprehensive CV, and 5 publications on a single topic. Each year, an awards committee, specifically formed by the ASB past president to evaluate the Borelli nominations, selects the recipient from a slate of incredibly qualified and remarkably accomplished candidates, and this year was no different. The Borelli Awards Committee includes at least 5 members spanning the ASB disciplines and includes the president-elect, and at least 1 former Borelli winner, with the caveat that all standard conflict of interest considerations are taken into account when forming the awards committee. With that context in mind, I'd like to inform you that the 2019 Borelli Award Committee has chosen Professor Irene Davis from Harvard Medical School. At Harvard, Dr. Davis is professor in the Department of Physical Medicine and Rehabilitation and director of the Spaulding National Running Center. She is also a professor emeritus in the Department of Physical Therapy at the University of Delaware. The Spaulding National Running Center is an integrated research and clinical center whose mission is to reduce overuse musculoskeletal injuries in active adults. The clinic is one of the only full-time clinics exclusively devoted to running-related injuries. They have seen nearly 700 patients in the running clinic since its opening in April 2012, averaging approximately 100 new patients per year. Dr. Davis's responsibilities include general oversight of the clinic, and she also spends 8 hours a week in direct patient evaluations. From her nomination letter, I can tell you that the scientific essence and importance of Dr. Davis's body of work is eloquently described by her former PhD mentor, Dr. Peter Cavanaugh, who was also a winner of the Borelli Award in 1994. He says, "Irene Davis is a uniquely qualified individual. She straddles the divide between basic research and clinical practice in the area of human locomotion better than anyone I know of. She's an international leader in running injury research, and her major contributions to the field are pioneering studies that have changed the way we look at running injury and the prevention of running injuries. Her name is known and respected wherever studies of running mechanics are conducted. For example, at a recent meeting of the International Society of Biomechanics, I repeatedly heard Dr. Davis's work referred to as the gold standard. How would the field be different without Dr. Davis's contributions? The area of running injury mechanics would still be mired in descriptive scientific studies that lack clinical relevance. There would also be no indication that running mechanics can be voluntarily changed." As evidence to these words from Dr. Cavanaugh, I would like to note that the 5 publications submitted with Dr. Davis's Borelli nomination focused on the topic of knee pain and mechanics. 2 of the 5 publications were prospective studies, and the group of these 5 publications alone have over 1,000 citations. Since we're scientists, we like numbers. In total, Dr. Davis has over 140 peer-reviewed publications and an H index of 66. Since we're humans, we like to think about the mentees. She has mentored 36 undergraduate students performing independent studies, 22 master's and doctor of physical therapy students, 22 doctoral students, 22 residents or fellows, and 21 postdoctoral researchers. In addition to the extreme level of accomplishment in research, Dr. Davis has also been an extraordinary citizen and leader in the biomechanics community. She was an ASB program chair in 2005-2006. She was elected ASB president, serving the 3-year term that spans president-elect to past president. She has established and organized 11 research retreats. She is a highly valued speaker and has inspired many throughout the world. She is the recipient of the Career Excellence Award in Biomechanics Research from the American Physical Therapy Association and the Biomechanics Career Award from the American College of Sports Medicine. She has been identified by Runner's World as one of the 50 most influential people in the sport of running. Believe it or not, I could go on, but I won't because you're here to see the main event. Ladies and gentlemen, it brings me great pleasure to introduce Dr. Irene Davis, the recipient of the 2019 American Society of Biomechanics Borelli Award.
Wow, there's a lot of you out there. One of the greatest honors in a professional career is to be recognized by your peers. So I first just want to say a heartfelt thank you to all of you and to the society. I am a physical therapist and I've remained active throughout my career, and I entered biomechanics because I really truly wanted to utilize biomechanics to inform clinical practice in the treatment of overuse injuries. And it's for that reason that I decided to focus my Borelli talk on that topic. I want to start out a few words about Giovanni Alfonso Borelli. After studying some of his works, I realized that he and I have some things in common, and I feel a bit connected with him. So my family came from a very small town called Gaeta, which is not far from Naples, Italy. He's one of the founders of iatrophysics, the application of physics to medicine, which is where I feel I fit best. He was clearly a student of movement, and he believed that nature really knew best when it came to movement. And that's the lens through which I see movement as well. In terms of movement, one of my favorite books on this topic is Spark by John Rattay. He's from Harvard Medical School as well, and it's a book on exercise in the brain. And he starts out talking about this very interesting little animal in the sea called the sea squirt. And it's got a very primitive brain, and it swims for some time looking for a place to attach to. Isn't that beautiful? Once it attaches itself, it stops moving. And once it stops moving, it eats its brain, presumably because it's no longer needed. So I think it really highlights how important movement is for our brain, but we also know it's critical to a healthy musculoskeletal system. And then the wrong movements, though, repeated over many times, can also be detrimental to the musculoskeletal system. Since overuse injuries are common in running, it was the movement that I decided to study. I believe running is an activity of daily living. It's not just a sport. You have to run after that train or after your little one or away from the boogeyman. And in fact, if you watch your toddlers, the minute that they can walk, they want to run, right? So it's innate in us. I think running is in our genes, and this article by Bramble and Lieberman talk about how when we went from Australopithecus to Homo erectus, that we had changes in our body structure that optimized us for running, particularly endurance running. And these are just a few of the changes that happened as we went from walking to running. Now, unfortunately, even though we were adapted to run, on average, 30 to 40% of runners get injured in a given year. And I always say that would be like birds getting wing injuries or fish getting fin injuries at that same rate. And it begs the question, at least to me, as to why. Now, one explanation, it's probably very multifactorial, but one explanation is this mismatch theory of evolution. And what it states is that the environment is changing faster than our bodies can adapt, and that we're no longer living the lives that our bodies were adapted for in terms of food, air, and clearly activity level. And they believe that this is the cause of many of the non-communicable diseases today, diabetes, obesity, cardiovascular disease. These are preventable diseases. And I think this can extend to the musculoskeletal system. So just for a minute, let's consider perhaps we're not running the ways our bodies were adapted. I think that it's possible that some of the modern, really highly supportive footwear may lead to deconditioning of our feet. We know that weak feet are related to things like plantar fasciitis. What you're doing right now is one of the most unnatural things, right? Sitting. Sitting has led to weaknesses in our core, and we see lots of core instability in runners and deviations like this that are often related to knee pain. So part of my mission is to understand how do we restore natural movement in a modern world to prevent musculoskeletal injuries. I think about injuries in a multifactorial way, of course, and from a biomechanical standpoint, you have your structure, that's what your parents gave you, can't do much about that. You have your mechanics, that's how you translate your structure into movement, and then there's dosage, how much you do. So you can have normal structure, and anyone who's a clinician has seen this, the minute someone starts to move, they fall apart. That can put you over the injury threshold. Or you can have normal structure, normal mechanics, and just train improperly. For the purpose of this talk, I'm going to focus on mechanics. Now, mechanics in biomechanics is thought of as kinematics and kinetics. I'm going to talk about it a little bit differently in terms of alignment and loading. So a malaligned limb can result in abnormal loads to the musculoskeletal system. A normally aligned limb that is landing really, really hard, pounding the ground into submission, can also have increase the loads to the musculoskeletal system. And you can also have both of these, abnormal alignment and abnormal loading, which I call the double whammy. So the goal, I think, in all landings should be well aligned and soft. So I've tried to take a very strategic approach to solving running injuries. Start with the most common injuries, establish relationships between mechanics and injuries. Then you develop interventions once you've established those relationships to alter these mechanics. And then you need to determine, do these interventions actually result in a change in injury? And then finally, you translate it into the clinic. So in terms of the most common injuries, if you look at this injury pie, you can see that 75% of injuries occur at the foot, knee, ankle, lower leg, or from the knee distal. I'm going to, for the three of the most common injuries is patellofemoral pain, iliotibial band syndrome, and tibial stress fractures. So I'm going to focus some of my talk on these three particular injuries. We'll start with patellofemoral pain. So we know that in a normal healthy knee, there's an equal distribution of load between the medial and lateral patellar facets. And you can see that on this picture on the left. I borrowed this picture from Chris Powers. Thank you, Chris. And you can see here the femur is excessively internally rotated. So now there's excessive loading on that lateral patellar facet. Now that's a lot of loading, but Chris Powers' group has also shown that small changes in relative rotation between the patella and the femur can significantly alter the patellofemoral contact profile. Cadaveric studies have been done that show that the patellofemoral contact profile increases with increased hip adduction. So some of these hip mechanics seem to be related to the development of patellofemoral pain. So we've conducted some human studies, and this is the work of John Wilson, looking at women who have patellofemoral pain versus age and mileage matched healthy controls, and you can see increase in hip adduction in those injured groups. Brian Noren won the Clinical Biomechanics Award for this paper and showed that 15 runners who had anterior knee pain had significantly greater hip adduction. Remember, this was done prospectively than the healthy controls. And so it suggests that this hip adduction is an aspect that is increased in people who have patellofemoral pain, and this is also supported by another meta-analysis. If we look to iliotibial band syndrome, it's the second most common injury at the knee. We know that this is a friction-related injury. The IT band moves posteriorly, and it creates friction between the IT band and the lateral femoral condyle. And it's often associated with downhill running, so people have thought maybe it's a sagittal plane knee flexion mechanism. But a study by Orchard showed that there's really no difference in the sagittal plane mechanics of people who have IT band syndrome versus those who do not. So we thought maybe this is, not a sagittal plane mechanism, and we decided to look a little further. We started out by doing a very detailed anatomy dissection. It's always fun to get back to the cadaver. And what we saw is that the IT band clearly does attach to Gerdy's tubercle, and that's what we all learn in anatomy, right? Also attaches to the lateral patellofemoral ligament. But what I never realized is there's a very robust attachment at the distal femur. And because of that attachment, increased hip adduction is very likely to add load to the IT band. So we conducted two studies. One of them was retrospective, and this is one that was published by Reed Ferber. And we found that indeed, people who have a history of that injury had increased hip adduction. But you understand that a retrospective study doesn't really give you cause and effect. The problem is you don't know if you're looking at the cause of the problem or actually the effect of the injury. So we followed, there's also a prospective study that was done again by Brian Noren. And what we found here is, again, hip adduction was increased in those who went on to develop IT band syndrome. So again, hip adduction seems to be associated with IT band syndrome. Moving on to tibial stress fractures, if we think about impact loading, I think we all understand that loading is very important to bone development and bone health. However, too much impact may actually be detrimental. If you look to animal studies, Radin has shown that if you take rabbit tibia and deliver axial impact loads, they develop tibial stress fractures. The same group found that if you apply very sinusoidal loads to the cow joints, that cartilage will remain healthy, but the minute that you start to introduce periodic impact loading, you have rapid cartilage wear. So it suggests that at least bone and cartilage are susceptible to this impact loading. Now, in looking at human studies, just want to talk a little bit about differences between foot strike patterns, because it's very relevant. If you land with a rear foot strike pattern, we know that you have a very distinct impact peak that is missing when you land with a forefoot strike pattern. So the rear foot strikers tend just naturally to have higher load rates than forefoot strikers. It does matter. So we conducted a study, and this was with Claire Milner, looking at the history, rear foot strikers with a history of tibial stress fractures, and looking at these load rates. So she looked at both the average and the instantaneous load rate on that first rise to the impact peak, and she found that the impact loading was higher in both instantaneous and average. What's interesting is the peak loading, which is twice that of the impact peak, was not different between those who got injured and those who did not. And we've not found that in any of our other injury studies as well. It seems as though it really is that early high load rate that seems to be related. This also has been supported by meta-analysis. These load rates are also seem to be associated with patellofemoral pain. This is a study by Caleb Johnson, and he looked at 30 individuals with active patellofemoral pain and compared to 30 controls, and looked at the instantaneous average load rate, but also looked at the posterior or the braking load rate as well, because there had been some recent studies showing that that was related to injury. Here are his results, and you can see the blue are the patellofemoral pain, and these are active again. All were higher than those who were healthy in both average instantaneous and resultant as well, but there were no differences in the posterior load rate. So why would these load rates matter to a patellofemoral joint? If you look at a rear foot and a forefoot striker, just to show you the difference here in the load rates, so the load rate's going to be higher in the forefoot striker, and because of that, at the very same point in time, the force is going to be higher because the slope is higher in a rear foot strike. So if we're looking at early in stance here, the other thing that happens is a rear foot striker has a tendency to land with their knee in more extension. That causes the patella to be more proximal, the contact area is reduced. So what you have here, higher force, lower area, or an increased patellofemoral contact stress. So I think this is how it could be related. That increased stress has been related to knee pain in runners. We've also looked at load rate in terms of groups of injuries as a group, so not any individual, but grouping them together. This was a prospective study of 250 healthy runners. And what we found is that runners with load rates greater than 66 body weights per second were almost 3 times as likely to be in the medically diagnosed injured group versus those that were never injured. In another recent study by Erin Futrell, she looked at active injuries. So these are 93 injuries compared to 32 healthy controls, and she found the same thing. She found that injured runners were 26% higher in their load rates than their healthies. So let's just summarize what we found for our assessment of relationship between mechanics and injuries. There seemed to be, and this is not exclusive, I don't mean it to be, but if you're looking kind of for the lowest hanging fruit, increased hip adduction is related to patellofemoral pain, IT band syndrome, tibial stress fracture, which I didn't talk about, and there are others likely that it's related to that haven't yet been studied. So femoral acetabular impingement, adduction and internal rotation are some of the hallmarks of that particular problem. And anything that, when you medialize the knee with respect to the foot, and causes medial loading of the foot, so things like posterior tib tendonitis and plantar fasciitis. So these are areas that others can look at. In terms of high impact loading, we found that it's related to tibial stress fractures, bony and soft tissue injuries, so groups of injuries, patellofemoral pain, and I didn't talk about this one either, but plantar fasciitis. So if we have established these relationships, and this is where I take off my biomechanics hat, put my clinical hat back on, reducing these mechanics should reduce injury risk, but how do we do that? So one of the most common ways a clinician will try to change alignment is by strengthening the muscles that control that movement. In a study of patellofemoral pain, though, 5 years after strengthening, the patient still had pain and they had reduced activity, even after strengthening. So the question is, why does strengthening fail in the long term? This is a work by Rich Willey, who decided to look at 40 runners with increased hip adduction, and he randomized them into a strengthening and training group, a strengthening and control group. And so the strengthening group had 6 weeks of standard type of physical therapy exercises aimed at the abductors and external rotators. The other group did no activity, and not surprising, the trainers got stronger. We also looked at their mechanics pre and post, because if those muscles that got stronger really truly control that motion, we should see a change. This is the hip adduction, and the black is pre, the red is post. This is internal rotation, and this is contralateral pelvic drop. These are all motions that those muscles should help to control, and there was no change. And in fact, if you look at the peak values, black is pre, blue is post, the difference is they look identical to the group that didn't train at all. So this suggests that maybe we need to address something else. We call this muscular system the hardware, and really the motor pattern the software. But I really wasn't a motor control scientist. I had to get into the literature, dig into it, and came across Carol Lee Winstein's work. And what she said is, if you want to internalize a motor skill, you have to have two phases: acquisition and transfer. So the acquisition is where you give extrinsic feedback on a predetermined schedule, and it develops the inherent intrinsic components of kinesthesia and proprioception. Then you have to transfer it. And what you do there is you gradually remove the extrinsic feedback so you can rely on the intrinsic components. And a phased feedback integrates those two programs gradually, the two phases gradually. So we did a lot of pilot work to come up with what we thought was an ideal kind of schedule of phased feedback. And Rich Willey took this on as his dissertation and looked at a mirror retraining study. He had 10 recreational runners with patellofemoral pain, not a year's worth, but 4.5 years on average of patellofemoral pain. So many of these are chronic. What we did is we brought them in, we did initial video screen to see if they looked like they had the adduction and internal rotation. If they did, they came in for a motion analysis, and if their hip adduction exceeded our normal value, they were included. They were taught to activate their glutes, because the glutes help to increase adduction and external rotation while looking in a mirror. And this was our phased feedback design. So we have 8 sessions over about 3 weeks, starting with 15 minutes, going up to 30. The pink is the feedback, so you can see halfway through, we start to fade the feedback throughout the sessions. And there are the results. So we were focused on hip adduction. You can see from pre to post, every single one of these subjects showed this kind of reduction. So there's a significant reduction, but more importantly, because if you do all this work, you want it to persist. You can see that it persisted at both the 1 and 3 month follow-up. So it suggests that yes, indeed, you can change alignment, and yes, indeed, it can persist. I don't have time to talk about this. We do this in all kinds of different deviations, from toe in, toe out, supination, pronation, crossover, Y-base, whatever, leaning, whatever the mechanic that you think is causing the problem can be retrained. And we do this in walking and in running. You just need to know what to change. You need to have a strong clinical hypothesis for that, and you need to provide appropriate feedback and practice. So now I'm going to talk a little bit about interventions to address our impact loading. In this study, we screened 20 subjects who had high tibial shock. So we're using tibial shock for this particular intervention. And what we did is we gave them feedback on a monitor in front of them. Now, this is one of the old PCP accelerometers that's wired, so you couldn't do this outside. But you can see that in a single session, they are able to reduce their tibial shock in half, right? And I think if they can do it one foot strike, I can reinforce it. So it's really very powerful. But we still proceeded with that phased feedback program, and these are our results. And this has been published by Brad Bowser. We had a post-control session, but if you look at our baseline to post-retraining, we also looked at 1, 6, and 12-month follow-up, and you can see that they were reduced their tibial shock, and it maintained out to a year. We also looked at vertical average load rate. This was running over ground. Now you can see that the reduction is less, but typically you'll get the greatest reduction in the variable that you give the feedback on. But this suggests that indeed impact loading can be changed and it can persist. Now this is, I think, a really interesting study by one of our past postdocs. That's not Chan. Chan is the first author, but that's Roy Chung. I wanted to include his picture. And they took 320 runners, healthy, these are healthy runners, randomized them into a gait retraining program, and he used the same type of phased feedback design because he went through our training. He instructed them to eliminate the impact peak by running softer, and many of them did transition to a forefoot strike to achieve this. So he looked at them pre and post, and on the left you can see the pre-training, the control groups in the dark, the gait retraining in the dotted. You can see there was a significant reduction in those that did the retraining. The control group got 8 sessions of running, starting with 15 minutes up to 30. The only thing they didn't get was the retraining. So it does appear that we can make these changes. But now we need to know, do these changes actually make any difference? Because the patient doesn't really care about whether their hip is dropping or whether they're hitting hard. They care that their knee hurts and they want to be able to run. So I'm just going to go over a few studies. This is a study by Rich Willey. I just want to give you the functional outcomes. What they found is the VAS pain score decreased by 80%, and it persisted at the 1 and 3 month follow-up. So yes, that was successful. We had the same kind of success with a study done by Brian Noren as well. Angie Diebel was looking at people with compartment syndrome, chronic exertional compartment syndrome, and she retrained them to be a forefoot striker and looked at them 6 weeks and 1 year follow-up. And the SANE and LLOS are 2 functional outcome scales. And you can see that at the baseline, at the 6 weeks and the 1 year follow-up, that they improved almost 100%. So significant increases in their functional outcomes, and they were all slated for surgery, and none of them had to have the fasciotomies. The last one I want to talk to you about is Genevieve Roper. She took 16 runners with anterior knee pain, randomized them into a control and to a forefoot strike gait retraining program, and looked at them at baseline and afterwards in 1 month follow-up. And what she found is the forefoot strikers had significant less pain than control, and that persisted at the 1 month follow-up. So the control group, again, they went through the running, they went through the same kind of program, they just did not get feedback. So, and all of these utilize this real-time feedback with a phased feedback design. I think that's really important. I don't think it's enough to get someone on the treadmill and say, do this. Again, I want to highlight this paper because I think the 1 year follow-up is probably the most exciting part of this paper. And so what they did is they looked at injuries over the course of a year. And this is a survival graph. And this is so impressive to me that they had a 62% lower injury risk in gait retrained runners compared with their controls. That's huge. And these were healthy runners. So this is actually one of the first studies to suggest a prospective intervention in healthy runners. Now, I want to talk a little bit about whether footwear matters, because I never used to think it did until I started looking at all 700 of those runners that come through our clinic, barefoot and minimal shoes and their own shoes. And it really started to awaken this sort of observation in me that I think it really matters more than I used to think it did. This is a study that was published by Dan Lieberman's group, and what they did is they went to the Eldoret region of Kenya, and they asked a group of high school kids and a little bit older what kind of footwear they were habituated to. And then they had them run, and they monitored their foot strike pattern out in the field. And this is their results. So they had a group that they classified as always shod, mostly mixed, and always barefoot. And what you see is that when you're always barefoot, you're primarily a forefoot striker. And when you're always shod, you're primarily a rearfoot striker. And the more often that you wear shoes, the more you tend towards the rearfoot strike pattern. So it suggests that, yes, footwear does affect mechanics. I think the sole, and I think Benno did a study on this very early on, talking about, sole flares, and clearly sole flares do influence mechanics. If you look at this shoe on the left, it's got a posterior heel flare. And when you hit the ground reaction force then has a moment arm and creates a plantar flexion moment. So that really causes you to plantar flex quickly, and so the anterior tib has to work really hard eccentrically to try to control that. If you look in the medial lateral direction, what you see is the same thing, except it's in another plane, and that flare actually increases the pronatory moment on that shoe. Casey Kerrigan has also done some work looking not just at the foot, but up at the knee and the hip, and found that when you look at barefoot compared to a conventional running shoe, that it increases torques all the way up. Now, I also want to talk about flares on the forefoot because I think they're just as important. This is a videotape of somebody who forefoot strikes and has always done it in regular shoes. Now watch her landing. She's landing in excessive inversion, a lot of plantar flexion, and that puts a lot of, it results in an increase in the excursion and the velocity in both the eversion and in dorsiflexion. So greater foot excursions, greater foot velocities. We had a patient that came through the clinic who had transitioned herself to forefoot striking in a pair of regular shoes. And this is how she looked. And she had peroneal and Achilles tendonitis. And this is a frame of her as she's striking the ground. She's got increased plantar flexion and inversion. Look how high her heel is up from the ground. Now, we put her in a pair of minimal shoes, and I promise you we gave her no instruction at all. And what you can see when she got out of the shoes that had the flare, that her plantar flexion and her inversion had decreased. So there really does seem to be an interaction between footwear and foot strike, and this was highlighted by some work by Hannah Rice. And what she did is she looked at 3 groups of runners. These are habituated. Rear foot strikers in standard shoes, forefoot strikers in standard shoes, and forefoot strikers in minimal shoes. And she looked at, we're going to look at all of the components, but when you look at the AP and the medial lateral load rates early in stance, what you end up seeing is that the forefoot striker in the regular shoes had the highest AP and ML load rates, right? So if you then take and look at all components, so what we have here is the resultant ground reaction force on the left. When you look at the resultant, you see that rear foot striking in regular shoes and forefoot striking in regular shoes ends up with the exact same load rate in the resultant load rate, the same magnitude. So, and that is the total load rate that we experience. But the reason for that is that because the forefoot striker in the regular shoes has higher AP and ML, despite the fact that they've got a lower vertical, it compensates for itself and they end up being equal. And if you look across all of the components, the forefoot striking in the minimal shoes results in the lowest load rates. So the softest landings, if you're looking for softest landings, are at forefoot strike pattern in minimal shoes. So the next thing I want to talk about is whether feet are weakened with chronic support. This is a study not of footwear, but of orthotics. And they looked at the effect of 12-week orthotic use on the cross-sectional area of intrinsic muscles. They looked at flexor digitorum brevis, abductor digiti minimi, and abductor hallucis. And in all 3 cases, over just 12 weeks, the cross-sectional areas reduced between 10 and 17%. That's just in 12 weeks. Consider how long people typically wear orthotics. So another question that I get asked in terms of minimal shoes, and this is all sort of forming my clinical hypothesis for how we approach patients, is forefoot striking and minimal shoes bad for the Achilles? Because I think there's a lot of people that feel that it is. And I think if you transition too quickly, it can be. But if you look at the studies of habitual footwear, this was by Histon in 2016, people who are habituated minimal shoes, their Achilles tendon is larger in cross-sectional area, has lower elongation, and 90% stiffer. And a stiffer, stronger tendon is a healthier tendon. When you look at habitual strike patterns, so this is not footwear, but strike patterns, Scott Waring, using elastography, found that habitual forefoot strikers have greater stiffness, again. So, maybe if you're habituated and you do it slowly, it actually could be healthy for our tendons, right? But we do need to adapt to a forefoot strike pattern if you're going to go with that in minimal shoes, and these are the areas that get loaded, for sure. So you have to strengthen the extrinsic muscles, the calf, you have to strengthen the intrinsic muscles. You have to progress slowly, but it's really not like any other new activity that you would get engaged in, right, in physical activity. So we've developed a foot core program, and it starts with doming, and you all should try this sometime. But what you do is you put your foot on the ground, stiffen your toes, draw the ball of your foot back towards your heel. It's also called a short foot exercise, and squeeze your arches. And if you cramp, you've got weak feet. We follow that with a number of other exercises. We do toe curls, we do doming and hopping on 1 foot, 2 feet, work on the calves through heel raises. Ab and adduction, these are important muscles. You have an abductor digiti minimi and abductor hallucis for a reason. And the abductor hallucis is very important for the maintenance of the arch. This is the foot, this is actually a foot of someone in the room, of someone who goes barefoot a lot. She knows who she is. And this is the foot of my 1-month-old granddaughter who had it right from the get-go. So if you can't do this, I promise you, you had it when you were born. So can you strengthen feet with minimal footwear? This was a study we did with Sarah Ridge. This is, I think, such a cool study. 57 subjects randomized into a control group walking in regular shoes, a foot strengthening group, and a minimal footwear group. And what they found, and she used cross-sectional area using ultrasound, what she found was that there are similar increases in the cross-sectional area of these muscles between minimal footwear and a foot exercise program. The program was an 8-week program and contained a lot of the exercises that I showed you. That is extremely powerful. That means if you put on a pair of minimal shoes and you walk, and we went from 2,000 to 8,000 steps over the 8 weeks, we probably could have increased that a little bit quicker. That's very powerful. That's walking, and there've been a lot of these studies. I'm just going to highlight a couple. This is one that we did with Roy Chung. They had 38 subjects, and this was for running, and they used a volume by MRI, so a little bit different. They did prepare them, because running is a greater demand. They prepared them with a 3-week calf program, but their foot volumes were significantly increased by transitioning to this minimum footwear. So I'm going to suggest that perhaps it's a time for a paradigm shift in thinking, like just to open the mind a little bit and think maybe rather than support and cushion this foot, that we leverage the strength and cushioning that we have in our feet with all these bones and articulations and arch muscles. We have 4 layers of 10 arch muscles, and that's pretty incredible, right? And maybe we can develop these foot abs of steel. That's what we're aiming for, right? So when I talked about these approaches to solving injuries, the last thing is translating it into the clinic. And so what we do now, we use all of the information that we gain in these studies. We now start people walking in minimal shoes from the day one, because we know that's going to be, it's a low load and it's going to help strengthen them. We build the capacity through static and dynamic activities. We have criteria before we ever put them on the treadmill. And then we do the feedback and address whatever issues of alignment that we have with them. I want to show you just a couple of clinical results. It's always good to show them. This is an 18-year-old female, right IT band syndrome. She had 2 unsuccessful courses of PT. Those are the people I think that may have an underlying mechanical problem. Not everyone does that has a running injury, but these people do. This is her afterwards. Now, she doesn't really care that her mechanics changed. To me, that's what I get excited about, but she cares because she can now run. This is a 32-year-old male with left patellofemoral pain for 2 years, had 3 unsuccessful courses of PT. This is his loading profile originally. These are very high for those of you who don't do this work, are very high load rates when you get into the triple digits. And this is his load rates afterwards. So we reduced him by about 50-60%, and both were able to run pain-free. So where are we going? Just like everyone else, we're all going out into the wild with wearable sensors for sure. We are developing machine learning algorithms to detect footstrike patterns, working to develop a mobile retraining system that can help provide feedback, both kinematic and kinetic, to the runner out in the field, because it's very different out there. They have distractions. It's, they respond to fatigue differently. And we want to be able to do that in a natural environment. And hopefully this will be something that we can then send that information back to the PT and the coach so that they can get that information as well. So we can get people out of our clinics sooner and out into the wild. What have I learned so far? Chronic recurring injuries are often related to faulty mechanics. They can be changed and the changes can persist, but they require adherence to motor control principles. Forefoot striking results in the softest landings, promotes stronger feet and Achilles tendons, and reduces knee loads. So if it's something that you want to try, there's some advantages. I don't believe you should rear foot strike in minimal shoes. If you're going to land on your heel, you need to put cushion under it. But I also don't think you should forefoot strike in conventional shoes because of what we saw with those levers. And this is really exciting to me. Minimal shoes are not just for running. There are people like Isabel Secco who's applying it to knee-OA. I think it can be applied in the diabetic foot population before they develop neuropathies, in the pediatric population, and in aging. And I'm still learning, just like every one of you. My final thoughts are, this was actually from S.F. Stewart in 1972, and he says, the remedy for man's foot pains, I believe, lies in the more natural physiological use of his foot, which brings me back to Borelli, who said that nature is really the best way to determine how we should move, and kind of it comes back to how I restore natural movement in a modern world to prevent musculoskeletal injuries. So I have some people and organizations to thank. I have to thank my funding agencies. Obviously, we can't do the work without them, but really it's people. And these mentees are just a few, these are more the doctoral and postdoctoral students that I have worked with, an incredibly talented group. Each one of you and everyone that I've mentored has put a fingerprint on this Borelli Award. The ones in red are the ones that are our current team, and I've underlined Jeremy just because Jeremy Ardelais is our lab manager, and we could not do what we do without Jeremy, so he's really, I just want to give him a shout out. We have had a lot of international visitors from Asia and Canada and Brazil and Europe. So it's been fun because it adds a diversity to our lab in terms of different perspectives and different experiences. We like to have fun in our lab. We have something called Force Fun, and we've done a lot of great activities. It's just really fun to get out of the lab, and I have really enjoyed this. We love hats, so you might recognize some of those people. We also like Snugglies. And this is Reed teaching Daryl and I how to make wine. I have to tell you, it was the worst wine ever. We poured it all out. We also like to give back to community service. It's part of our mission. And I just want to thank my mentees for allowing me into your life at a time that you had so many great life events. So graduation and getting married and babies. And it's just a privilege to be around at that time. I also have to move on to thanking my collaborators, and some of you are in the room. You guys have made me think differently, and we've had some great discussions and also a lot of fun. And Peter Cavanaugh, who's not here today, he sent me a message which meant the world to me. He believed in me at a time when I was 30 years old, 6 months pregnant with a 2-year-old. And he had never had anything like that in his lab. And I really am grateful that he believed in me to take me on as a student. And he taught me to be rigorous in research and to ask the right questions. I have a special shout out to Joe, just because Joe and I it was my very first large grant, a DoD grant, so that's very special. And Joe has just been a mentor and friend to me throughout my whole career. And when people say that the people that you do your doctoral degree in will be your lifelong friends, believe me, they are. I can't say enough about these two women who are my colleagues in the iliotibial band backup group. Not only have we've done a lot of discussion of science, and we've just had a real blast together and shared a lot of life together, and I just am so grateful to you guys. And then finally, I want to talk about family. These are 3 people in my life that are no longer here. My dad, who taught me resiliency, my mom, who taught me to be fiercely independent, and my sister, who taught me bravery. These 2 young ladies were kids, were babies. They were my distraction during my dissertation and during my early career. But these are now my distraction, and I love every one of them. And then finally, I have to speak to this man here who came into my life at a time when it was really probably one of the most challenging points in my life. And he's been a rock and a true north, and always up for an adventure. So I just want to end by, again, thanking the Society for this award. It is one of the greatest honors I've ever had. Thank you.
Irene, it is my pleasure to present you with the 2019 ASB Borelli Award. Thank you for a spectacular lecture, and I have been told by Walter Herzog that there will be no questions because we are on time.